Okay, so I'm just going to go through incentive spirometry real quick and kind of hit the highlights. So first things first, whenever you have incentive spirometry and you have your test on incentive spirometry, or I guess it's on airway clearance or lung expansion, it's always important to know what you're looking at. Like, what is your patient problem? So we'll go through IS real quick. So IS is a lung expansion therapy, which means it's going to expand the lungs, get all the way down to the little alveoli. So the alveoli are the little sacs of what looks like grapes at the lungs, and that is where gas exchange takes place. Alveoli are, when they're expanded, they come in contact with the capillaries, and oxygen and carbon dioxide diffuse across the border from the alveolar capillary membrane, and that's where all the magic happens. So your alveoli are very important. So if you have something wrong that's causing your little alveoli to scrunch up and collapse, then it's going to cause oxygenation problems for the patient, which is not good. So atelectasis is basically when your big, fluffy, full, juicy grapes, called alveoli, become sad, crumpled up raisins. So your alveoli at the little unit collapse. It's not a lung collapse. A lung collapse would be like a pneumothorax. Atelectasis is a alveoli collapse. So think about it being a pneumothorax is the big whole picture lung collapse. That would be like the entire building collapsing. Atelectasis is more like a smaller unit, so it's like an apartment inside that building collapsed, but the whole building itself did not. So you're still weakening the integrity of the entire structure, but it's not a widespread, diffuse problem. But it's still a big problem because it's at the most integral level of your lung. So you need your alveoli to be open and big and happy grapes, happy, full, juicy grapes. Otherwise, you can't have gas exchange, and nobody likes raisins. Okay, let's see. Okay, so why would you need IS? So obviously, if somebody has atelectasis already, then you need to treat it. You also need to prevent atelectasis. So there's certain people that are more prone to it. So people who aren't getting up out of bed, kind of bedridden people who are having surgery. Almost all post-op patients nowadays are on an incentive spirometer. Half the time the nurses give it to them and they don't teach them how to do it. So if you go to clinic and you see one in a patient's room, pick that thing up. Make sure that patient knows how to use it, because I can tell you 9 times out of 10 when I walk into a room and the patient has been using IS for days, they're not using it right. And the nurse did not give clear instructions, and they're putting them at risk for post-operative complications like atelectasis and pneumonia. This is surgery patients with COPD. IS can improve your cough mechanism because kind of naturally whenever you take a big deep breath, you kind of want to cough. And if you have that big deep breath, you can generate a more forceful cough, which can help you get some stuff out. So contraindications. A big thing to remember when you're dealing with treatments is a contraindication is a no. A side effect is something that happens. It may not always be, it may not always happen, but it could be something that does happen, and it doesn't necessarily mean that you need to stop the treatment. It could be something that happens that you do, yes, I need to stop the treatment and maybe change it or modify it. Or it could be that you keep going and it doesn't matter. But a contraindication is something where if this patient has it, it's a no-go. We do not pass go. We do not collect $200. We go straight to jail. So if a patient cannot take a deep breath on their own with instruction and supervision, they cannot do IS. So you're sitting there and you're coaching them and they're just not able to do it. You've got your little 90-year-old lady and she is so weak and malnourished because all she drinks is wine and she doesn't eat and she can't take a big deep breath, or they just will not do it. IS is not going to benefit them at all. IS is completely patient effort dependent. You can sit there and yell at that patient, or no, not yell, encourage that patient all day. But at the end of the day, it is the patients who have to take the breath and who have to, do it correctly. So if they cannot do it, then they are not going to be on IS. So if they have an open stoma, which, like a stoma is the little hole, where people's trach is. So maybe they don't have a trach in anymore, but they still have a little hole. There's some special instructions for that. Okay, so another contraindication is my patient is not able to deep breathe effectively. So maybe my patient has a neuromuscular disorder and they just can't take a big deep breath because they don't have the muscles to support it. So that's a contraindication. Okay, a hazard. So a lot of patients, when they're doing this, they all want to get it done. They want to wham, bam, thank you, ma'am, get her done kind of thing. It's not really that kind of treatment. It's going to need, a slow, deep, steady breath that builds until you can't take it anymore. Then hold, and then cough it out, let it out. So patients tend to hyperventilate because they want to do this really fast and they want to do deep breaths. So you're going to want to make sure that in between, efforts that they take some normal breaths. Otherwise they'll get dizzy and they'll start to feel sick and that'll make them less compliant. It is possible to pop a lung. So remember we talked about pneumothorax earlier, how that is the big apartment building crashing down, whereas atelectasis is just the one apartment inside the building collapsing. So they could have a collapsed lung. This is a vagal maneuver, so you can stimulate the vagal reflex. So the vagal reflex basically causes your heart rate to go down. And, that can cause the patient to, crash. So you just got to watch the patient and everything. That's not really a complication you see a lot, though. Okay, so obviously your patient needs to be spontaneously breathing. And it also has a little happy face and a sad face. So it kind of gives your patient a visual as to how they're doing and they can kind of see it. And a lot of them use it as a game. I tell them to use it in between their shows. So let's say Grey's Anatomy comes on every hour. You're watching the show for an hour. In between the commercials for the new shows, pick up your IS and do it. This talks about the different types of atelectasis. So, once again, atelectasis is the collapsed alveoli, so the collapsed sacs. I'm not really going to go over that stuff because it's basically just kind of you just memorize the definitions. Okay, so the key factor to prevent atelectasis or to treat atelectasis is prolonged inspiratory effort. So what you're doing when you're doing IS is, is you're taking a big deep breath. But by taking that big, long, deep breath and taking a long time to inspire, you're giving that gas that you're breathing in time to diffuse all the way down to the bottom. Because your gas has to travel from the top of your lungs all the way down to the bottom. So if you don't give it enough time, it's not going to travel all the way to the bottom, and those little sad grapes will never be inflated. But if you give them that nice big long, all of my grapes are inflated. Okay, so I'm sure you all know how to do a IS. Just make sure you have a tight seal. Okay, so that's all I'm going to do with IS. Let's see, I think I'm going to go over to here. Actually, yeah, I'll go to that. So, I just want to quickly kind of go over something. Come on. My little pen clicky is not working. Okay, let's try it. There we go. Okay, so the first thing to do when you are, first thing I should do is, you have two things on your test. So you have lung expansion. Sorry, my handwriting is terrible on this thing. And then airway clearance. So lung expansion is to treat atelectasis or to prevent atelectasis. Okay. And airway clearance has to do with removing secretions. So when you have a patient situation, always look at your patient first. Your patient always comes first. I don't care what level you are in respiratory. If you are taking this class, or if you are in your last, couple of classes and you're in your mechanical vent and you're in the ICU, I don't care what your ventilator is saying, your patient comes first. Everything, all the data that you're looking at on the vent is completely reliant on the patient. So you need to evaluate at the source. So ask yourself, what is wrong with my patient? So, is my patient able to move secretions? Or is my patient able to take a deep breath? That's really the two questions you're going to have for this next test. Okay, so I'm going to try to pull this up real quick. Okay, so I'm going to go through some questions and kind of show you how I take tests, because learning how to critically think and kind of draw conclusions from your test questions and how to weed out the stuff you don't need is really important. Okay, so we'll start with number 1. So okay, here we go. So I have a patient is quite weak and is unable to raise the ball marker on a flow-oriented incentive spirometer to meet the set goal. The patient is becoming discouraged. What should be recommended? So first, what is my problem? So the problem here is the patient cannot meet the goal on the incentive spirometer. So they have a lung expansion problem. So we know that lung expansion therapies are IS, IPPB. I think PEP is technically lung expansion too, but I don't really think about that. So we have the patient, they're already on an incentive spirometer, but they are weak. She is quite weak, and she cannot raise the ball on a flow-oriented incentive spirometer. So the patient is not meeting the goal, and she is just... Sorry, I'm over here trying to die. The patient is discouraged and weak. So what can we do to help her? So we'll go through each one of the answers and say, is this helping the problem? Because a lot of them will look like great answers. They will be beautiful answers, and they are decoys. Because they may be a beautiful answer, but they're not helping my patient. So, have the patient continue trying. So I have a weak little old lady, and she cannot use the incentive spirometer, and she's getting frustrated. She even said, "Damn it." That's how frustrated she is, and she never curses. And I'm going to sit there and tell her to continue trying. Is this going to help my patient? No, because no matter how hard my little old lady tries, she's too weak. So that is not going to help my patient. Scratch it out. It really helps if you know an answer is incorrect. Visually, just take one line and scratch through it so you can kind of take it out of your mind. Recommend that the patient be switched to IPPB. So we said that IPPB is used for patients who maybe need a little bit more assistance because they don't have the strength to draw in that good breath. So would IPPB be good for this patient? Possibly. She is weak and unable to, generate that flow that she needs. The IPPB machine can generate the flow that she needs to get the tidal volumes that she has to have. So for right now, we'll leave that one unclicked. Now C is change the patient to a volume-oriented unit. This is a red herring. It offers what you might feel is a beautiful solution to your problem. Like, oh, my patient just needs a different type of incentive spirometer. But in fact, that's not going to help the problem. The fact of the matter is, the problem is my patient cannot expand her lungs because she is weak. And that weakness is the main contributing factor. So if we change her to a volume-oriented one, she's still not going to be able to pull the volume. So she's still going to be discouraged, and it's still going to be too hard for her. She's not going to be compliant, and in the end, this therapy is not going to benefit the patient at all. So that is not a solution. This last one, you will see a lot of questions with discontinue the treatment. I'm going to let you know that 99% of the time that's not going to be okay unless it is a contraindication. You can't discontinue the treatment without talking to the doctor and having a valid reason why. But because the treatment is not effective, it's not a good reason to discontinue it. It's find a solution because the patient is still weak and is at danger for atelectasis. If you discontinue the treatment, the patient will develop atelectasis and then pneumonia, and the little 94-year-old lady could die. So do not want to discontinue the treatment. We want to find a better way to deliver the treatment. So the answer would be B, recommend that the patient be switched to IPPB because this will overcome all of the hurdles that she needs in order to get their lungs expanded, get her sad little raisins to be big, full grapes again, and get her gas exchange well, and get her tidal volumes up, and generally just increase her lung expansion. Okay, so let's look at number 2. A 16-year-old postoperative appendectomy patient has clear breath sounds and normal vital signs. What should be recommended to prevent atelectasis? So, first off, what is my patient's problem? And I know you're tempted to say, oh, my patient has atelectasis. No, my patient does not have atelectasis. My patient is a healthy 16-year-old with clear breath sounds. And normal vital signs. So my patient is normal, but they are post-operative. So they just got out of surgery. So what should I do to prevent atelectasis? I don't want them to get atelectasis. I don't want them to get pneumonia. I want them to recover fast. So my problem is that I'm post-operative at risk for atelectasis. Now, would CPAP help the problem? I have a normal 16-year-old sitting in the bed and I'm trying to strap a CPAP on them. CPAP helps with oxygenation, but it would help prevent atelectasis, but the patient doesn't need it. They're normal and healthy. CPAP is not the first step for them. You kind of have to think about it as like a flow chart, and CPAP is not at the beginning of that flow chart. IS is. Okay, so let's look at PEP. On the surface, PEP looks like a good therapy, but they have clear breath sounds. Honestly, PEP is mostly used when patients have lung expansion therapy needs and they need also to clear their secretions. So PEP would be maybe an okay answer, but it's probably not going to be the best answer. Now IPPB, there is no need for IPPB with this patient. My patient is 16. They have good old healthy lungs. They have lots of muscles. They are raring and ready to go. They have clear vital signs and clear breath sounds. I'm not going to put them on IPPB because there are hazards to IPPB. IPPB could cause more damage than help this person, and they don't need it. So what would we do? Would incentive spirometry help my patient? Absolutely. Incentive spirometry would, when taught correctly and done right, prevent atelectasis and let them get out of the hospital nice and easy with little cost to the patient and to the hospital, and with little effort. Okay. So that was me just kind of going through some questions with you, just trying to show you how to kind of go about answering questions and looking at questions. So always look at what your problem is first, and then try to figure out, go through each one and say, is it helping? So if your problem is lung expansion therapy, and they say postural drainage does not help lung expansion therapy. So why would I choose that answer? It's not correct. I want something that's going to open up the lungs because they have atelectasis, not remove secretion. Now, if I have a cystic fibrosis patient and they are unable to clear their own secretions, why would I give them an IS? I wouldn't. That's not going to be what I want because my patient's problem is secretions and removing of secretions, and an IS isn't going to help that. Okay, so I hope this helped a little bit with your lung expansion therapy and your airway clearance. If you want, the really easy kind of thing to do would be to take a sheet of paper and draw a line down the middle and put your lung expansion on one side, and I would write, let me see if I can pull it up. Okay, so just do your lung expansion therapy on one side and your airway clearance therapy on one side, and I would do your indications and for each, whatever, and then your contraindications and your side effects, and then your methods of delivery, so like IS and IPPB and arterial drainage and cough assist. And then, list the things about those that you need to know. Putting them side by side and comparing them is the easiest way to note the differences, and it's the easiest way for you to correlate in your mind, when to use one or the other. So I really hope this helped, and good luck with your tests this week. If you guys need me, feel free to call me or get my information from Miss Coffee. You can always email me what kind of things you need help with, and I would be more than willing to do another one of these videos if it's helpful.